Well, welcome. Good evening. Thanks for joining us for Mastering Dry Eye Management with Eyes on Eye Care. Thanks for taking the time out of your busy evenings and lives and family lives to join us. I am joined tonight by my good friends and dear friends and colleagues in practice here at the Eye Institute of West Florida, by Dr. Nora Cothran, our optometrist specializing in glaucoma care, and my chief technician and right hand, Morgan Adams. And so we are all in practice together at the Eye Institute of West Florida here in Tampa, Florida. And tonight we're going to be kind of covering a broad variety of topics, hopefully all culminating in helping you run a more successful, more efficient practice, keeping the highest level of care. We'll start off talking a little bit about sort of a day in the life. What's the journey for a dry eye patient through our dry eye center? And hopefully, what we're doing is facilitating a seamless and somewhat frictionless experience for the patient, both as a patient and a consumer. We'll talk about in module two, really acknowledging what dry eye therapy used to look like when we all were in our training, in our practices historically. And we'll contrast that with what I think is a relatively new approach and an innovative approach to dry eye patients that I think will produce better outcomes, better patient satisfaction, a better consumer experience. In module three, we'll sort of acknowledge the fact that we can talk the talk, we can walk the walk, but how do we get patients to walk the walk with us? In other words, what do patients actually hear when we're talking to them? And how do we get them to acknowledge and really accept the treatment recommendations we have with the least amount of resistance possible and make good decisions for themselves? We'll close out with Nora talking about how we take a collaborative approach in our practice to really raise the level of patient care in our practice, make things more efficient in terms of timeline to relief for our patients, and really raise the bar on the level of care. We'll close out with a quick Q&A section. And so without further ado, let me hand it over to my right hand in practice, the one that makes it all happen, where the rubber meets the road, Morgan Adams.
Awesome. Thank you, Dr. Desai. As we know, dry eye is a poorly treated condition. In our high volume practice in clinic setting, we start by training our workup technicians to ask guided and focused questions during their initial intake exam. This is both validating to the patient and is most efficient as previously tried treatments have not worked for these patients. These questions include, do you ever notice burning, stinging, tearing, or irritation in your eyes? What have you tried in the past for your dry eye? And really in a very focused way. In our clinic, we have many different tools in our toolbox, so to speak, to treat dry eye. This determination is made following both physical and verbal exam findings. One thing we really focus on in our clinic is ensuring that our staff and providers are well trained on each dry eye treatment that we offer. Most of our staff has had these treatments performed for them. This helps them to speak from experience when communicating with our patients. It is worth mentioning diagnoses methods that we previously used, as many providers still find substantial benefits for these treatments. Some of these include dry eye questionnaires, tear osmolarity, skin allergy testing, and MMP9 or inflammatory testing. While these can be very helpful diagnosis methods, we noticed that they did not change our treatment regimens or plans, and we found that patients tend to get hung up on the numbers, even if their symptoms have improved overall. Although it is not consistently used in our practice, we do still use these methods on occasion for clinical trials, as these are helpful when it comes to data collection. A thorough medication history is very important to access any current or past oral or topical medication use that may be causing some of the dry eye issues. Some of these include, but are not limited to, different hypertension medications, antidepressants, allergy medications as well. Our staff is also trained to ask about dry mouth, dry skin, energy levels, digestive issues that they may be having, arthritis, thyroid disease, and past surgeries or medicated drops as well. This helps patients to understand that we may be taking a different and more proactive approach than they have previously experienced. If patients have experienced these symptoms, we often consider running an autoimmune blood work or lab panel to evaluate 4 different conditions. Some of these may include Sjogren's syndrome, lupus, rheumatoid arthritis, and/or thyroid disease. These results often prompt a referral to rheumatology or possibly endocrinology as well.
Morgan, when you run these kind of autoimmune panels on some of these patients, do they seem kind of surprised, or do they feel relieved when they get some answers back? Because they may have been suffering for a long time.
Yeah, oftentimes. And we actually hear that a lot from patients that they did not think that that would be the case coming in that day. But I do think it is very validating to the patient to feel that oftentimes that approach hasn't been taken for them before. And so it's something that we're looking for that's different. And what Dr. Desai tells patients is, we may run labs and everything is totally normal. And then that's really good for the patient. But we also may be catching something early that hasn't previously been diagnosed.
Yeah, Morgan brings up a lot of great points here. And starting out with the fact that when we're doing our sort of focused history taking, as we all know in clinical practice, sometimes asking open-ended questions of a dry eye patient will sort of result in a rather long narrative diatribe monologue, and no one's got time for that. So we want to make sure that our time spent with a patient is really focused on getting them from where they are now to a better relief plan and in the most efficient way. And so that history taking oftentimes takes the form, as Morgan indicated, of have you ever questions. So we want our very specific pointed questions to elicit in the patient's mind psychologically of, oh, wow, these folks really know what I'm going through. And then they feel sort of unburdened by the obligation of having to explain what they've been through. And then we can move on quickly to, well, let's talk briefly about the treatments that haven't worked, because we're not going to do more of the same. We're going to have a much more proactive approach to this and an interventional approach, as we'll talk about in a moment. And that's really, we oftentimes hear, as Morgan and Nora said, patients are sometimes kind of almost taken aback in a bit. And they're sort of saying, wow, this is the most comprehensive, thorough sort of medical exam I've ever had. And I can tell that this is a very different approach than anything that I've ever experienced in any other eye care provider's setting when it comes to my dry eye complaints. And so that's always reassuring to us. And I think it immediately, just in the way we do that intake questionnaire and the very quick approach to a systemic evaluation really engenders a lot of trust and immediate trust with patients, saying, I know these guys know what they're talking about. They understand what I'm going through. They understand that things haven't worked. I'm looking for something new, and we're going to be very thorough about this. And it immediately opens them up to now understanding that this is a whole new approach, and it automatically makes them a little bit more amenable to options that they may not have heard about, because now they're sort of psychologically set up to hear about options and new things and new treatments, not just more drops necessarily.
Neel, it reminds me of that quote. There's a quote that says, the good physician treats the disease, but the great physician treats the patient that has the disease.
I love
that. And that is very much what our culture is at our practice, is we're treating the person and not just focusing just right on the disease.
Absolutely.
Some great point.
Yeah, I would find also, Dr. Desai, a lot of our patients, when we do start talking about these different things and what we're going to be looking for, that there's so many times that patients say, oh, my sister was just diagnosed with lupus, but I don't know much about it. Or I knew that my mom had rheumatoid arthritis, but I don't know what she did for it, and it really prompts a lot of very important questions in conversation and dialect between you and the patient as well.
Sure. Sort of building on what Nora just said as well, when it comes to running labs or diagnostic testing, I think there is a role for diagnostic testing like osmolarity or MMP9 testing and Inflammadry, particularly as conversation starters, to say, this is a real disease. There are tests for it. but we're careful to point out to patients when we're doing a broad systemic laboratory workup for things like Sjogren's and autoimmune conditions in general, that oftentimes these labs will be falsely negative. And it doesn't mean that you don't have that condition. It just means that the disease state might be at a subtle stage right now. And the tests that we have to test for them are not sensitive enough. And so we kind of preemptively prompt patients to expect that these may come back normal, but it doesn't mean we're taking our foot off the gas. We're taking any less of a proactive approach in treating their real disease.
Mm-hmm. Absolutely.
One of the audience questions is actually already coming in, and the audience member would like to know what type of autoimmune panels do we recommend kind of as a starting point, or do we put them all together all at one time? Do we have a building block approach? Do we put them all at one time? And also, is our form kind of like a yes, no, or we kind of leave it open-ended?
Great question. Do you want to tackle that, Morgan? And I can pipe in too.
Yeah, I can. So, in our clinic, the way that we run lab testing and autoimmune testing, we have a template that's built into our EMR system. So I know that if Dr. Desai starts asking specific questions about any history of autoimmune conditions, or if I tell that he's kind of on the track to start asking questions about them, we have a full panel in there. And basically, what we do is we just select which ones we want. And we have associated drop-down diagnoses codes, which with each of those individual labs. And then we're able to print it directly from our EMR. So we can choose exactly which ones we want to order from that drop-down. So it would be something that would be super beneficial to have built into your EMR and to have it be customizable to exactly what you want to look for.
Great. So just more specifically, the test that we oftentimes run as part of this templated sort of dry eye evaluation looks very similar to what you might run for a uveitis workup, minus a few things. Obviously, in a typical dry eye patient, we're not going to be running HLA-B27 like you might for uveitis, but there's a lot of overlap there. So we're running a rheumatoid factor, we're running an ANA, we're running C-ANCA, P-ANCA for Wegener's and polyangiitis, respectively. We're running both the traditional Sjogren's test, the SSA, SSB, ROLA antibodies, but we're also running the new, relatively new, it's now 16, 17 years old, the SHO test, which are the parotid-specific, salivary-specific antibodies, as well as the carbonic anhydrase 6 antibody that cumulatively are the new SHO panel or the early Sjogren's testing panel that on average diagnoses Sjogren's about 7 years earlier than the traditional markers, hopefully allowing us to more promptly initiate treatment and get our rheumatology colleagues to take a more proactive approach to treating patients that we suspect have Sjogren's. What else are we running? We're running an ACE level to look at sarcoid. We're running double-stranded DNA to look for lupus, myeloperoxidase for lupus, a thyroid panel, not just your traditional thyroid panel T3, T4, TSH, but we're also looking for a thyroglobulin antibody because Hashimoto's, from my own personal experience as a patient of Hashimoto's and thyroid cancer myself, this is a very subtle condition that can be oftentimes missed in our younger patients that are suffering from some vague symptoms that are easily dismissed. And so we want to give credence to that and test for the thyroglobulin antibody as well, because these patients can be euthyroid, normal T3, T4, TSH, but they have a positive antibody and they sure do have Hashimoto's. They're at higher risk for thyroid eye disease as well as for sort of ocular surface disease as well. So that's kind of the sum total of it. I think I hopefully didn't miss anything there, but that's kind of our templated dry eye workup, very similar to uveitis workup.
Mm-hmm.
So is that your last slide, Morgan?
I had one more.
Okay, perfect. Please go ahead.
Yeah, my very last one was just talking about communications, or I'm sorry, I have two more, but I'll hurry through. So I wanted to briefly touch on the importance of clear communication on recommended dry eye therapies. with our referring providers. So our ODs or MDs, we get a lot of PCP referrals as well, PAs, nurse practitioners. This helps to ensure that their referring provider that sent the patient to us initially or is continuing their care knows that we're taking a proactive approach to treating the patient that we now share with them. We have multiple in-house optometrists that specialize in specialty contact lenses, including scleral and hybrid contacts. These specialty contacts are very effective for moderate to severe dry eye patients, as well as our post-cornea transplants or post-surgical patients as well. So we work really closely with them. Within our practice, most new dry eye evaluations are initially seen by our PAs or our ODs in-house. We are lucky to have incredible providers that we work with that are very well versed in our dry eye therapies and regimens. Upon initial exam, patients are typically started on the over-the-counter home therapies like tears and warm compresses. The patients may be started on immunomodulatory therapies at this visit as well. If the patient returns with no improvement and further dry eye intervention is needed, the patient is typically then referred over to us. So sometimes the patients end up with us first, sometimes we're working with our in-house providers as well. And then the last thing that I wanted to discuss is utilizing our local reps. This is something that we do a lot and I think is really beneficial. So just to take advantage of staff lunches and educational opportunities, this goes for both staff and providers. This helps us to stay on the forefront of new products and ensure that the staff is well educated on these drops and therapies. This is something that we do really frequently. Also, investing in staff education will show that you care. So Dr. Desai does lead a grand rounds for our team and our clinical staff and providers every 3 months. Each grand rounds is sponsored by a different rep, so this helps to keep our team up to date, and this is really important for us. In my experience, when it comes to staff training, knowledge is power. Continuous education and engagement leads staff to feel important, included, and excited about learning.
Great. So we're back. So before we really delve into specific treatments, how we get everyone integrated in the process and the experience of a dry eye patient and their journey through our practice, I want to kind of share with you an epiphany I had at the outset of my practice some 20 years ago. Fresh out of training, joining an academic center, fresh out of training in Baltimore. And I realized that there was such a dearth, such a need for ocular surface care, and that it represented such a huge untapped market. When you think about your typical dry eye patient, there are plenty of them out there, but your typical dry eye patient is going to be a female, head of household, 45 plus perimenopausal patient. When you delve even deeper into this demographic, you realize just how powerful this demographic is. They're the central cog in a very large social network of other dry eye patients that have been suffering, that have been treated dismissively for years. Like it wasn't really a disease, it was just a nuisance problem, that it was all in their head. It was dry eye was sort of like the polymyalgia or sort of psychiatric disease state of ophthalmology. And so when we realize that this dry eye demographic, your typical dry eye demographic, has been so poorly and dismissively treated, but yet is such a central cog in medical decision-making for not only themselves and their social network, but also for kids. When a son or a daughter wants to have LASIK, guess who's calling to make that appointment and making that referral? It's your dry eye patient. When a husband wants a clear lensectomy or is having some vision problems, guess who's making the calls to the eye doctor on behalf of their helpless spouse? It's your dry eye patient. Guess who comes in with a patient when they have a cataract? It's the daughter-in-law or the spouse that comes in. It's your dry eye patient. And so if we win these patients over and actually take a scientifically grounded, evidence-based approach to treating a real disease, not just a nuisance problem, treating them like they have a real disease that has real treatments, and they start seeing results, we'll have won not only this patient over, but their social network. And so there becomes this network effect that will help you grow your practice, grow your reputation in a community, and it helps support all of the other elements of your practice. When we looked at our own dry eye patients, this was an internal study I did in our practice in 2015. We saw that the patients that were coming to me for dry eye care had seen 2.3 other eye care professionals, MDs or ODs, within just the last 3 years for dry eye complaints. And most of the time, the treatment modalities were reach into a sample cabinet, here's some artificial tears, please shoo out of my office, and stop complaining. And obviously, our treatment approaches have improved. We've also realized early on that ocular surface disease was so central to our bread and butter because the devil's really in the details, right? We spend so much time talking about these sexy technologies of femtosecond lasers and astigmatism correction and all of these wonderful new advanced intraocular lenses when it comes to cataract surgery, sort of my wheelhouse and passion. We talk about a little bit about all of the advanced biometry and the emphasis on getting good biometry, new lens formulas that has definitely helped. But there's almost been a neglect of talking about the role that ocular surface disease plays in our final outcome. And so, in a sense, I kind of feel like our industry as a whole are all students at this Midvale School for the Gifted. We're awfully smart, but sometimes we miss the big picture. And the big picture really is ocular surface disease. And so times have changed over time. Our views in medicine have changed, appropriately so. And so our dry eye therapies and our approach to a dry eye patient have necessarily changed as well, hopefully for the better, as opposed to Dr. Gray here. I made my attempt coming out of training. This is 2004, 2005. Coming out of training of trying to summarize for my team members that I was building around me my approach to dry eye. And this was my handwritten, I pulled it out of the archives, my handwritten sort of thought process to evaluate a dry eye patient. And believe it or not, in this era, the only real treatment, prescription therapy for dry eye was Restasis. That was it. We didn't have any of these other treatment modalities. And so you can imagine how much more complex a treatment algorithm could be and how bewildering it might be both to patient and clinician. And so it's only gotten more complex. This can lead to patient confusion. So there's sort of the analysis paralysis. There's too many options. I don't understand the disease. I may as well just neglect it. And so you get sort of this analysis paralysis. Or worse yet, you have a confused patient and a confused clinician, and they're not really sure what to do first and what order. And that leads to patient paralysis as well. So they don't trust the doctor, they don't trust the recommendation, and they sort of default back to, let me just keep using artificial tears. We also kind of have the effect with these treatment algorithms that can be very complex of almost sort of taking a formulaic approach to dry eye management or any other disease state management. And when that becomes the case, the patients will perceive that we're almost robotic, that the treatment recommendations that we have are formulaic, very robotic, and not really tailored or customized to their particular situation and case. And so we will lose our patients' trust and confidence in that way if that becomes the perception. They will not adopt our treatment recommendations or stick to them. And so compliance becomes an issue. And this often yields to patients bouncing and going doctor shopping. And that's why we see patients seeing 2 or 3 other eye care providers within a few short years. Our traditional approach to patients, sort of the Hippocratic method of evaluating patients, we start out with obtaining a chief complaint. Again, as we talked about, asking an open-ended question of, what are you noticing with your dry eyes? How do your eyes feel? These open-ended questions. Obtaining a chief complaint alone could take 15 minutes if we're not careful with a dry eye patient. So pointed, focused questions so that it resonates with the patient, that we know exactly what they're going through. And we can now have a forward-looking approach to how are we going to treat it and how is it going to be different and how is it going to work differently than what has failed in the past. A brief focus review of systems. I'm asking questions that are very pointed, sort of yes or no disguised questions to get through their entire medical history, targeted things that can help us elicit whether or not they may have high risk factors for autoimmune disease. We're going to look at a focused surgical history, things that we might iatrogenically create dry eye with, like refractive surgery, RK, PRK, LASIK, etc. Even cataract surgery, large incision cataract surgery can induce dry eye. Postoperative regimen after various ocular surgeries can induce dry eye, lid surgeries, etc. Oftentimes, our traditional approach in looking at past treatments focused on all the things that didn't work, and we'd spend a lot of time talking about things that didn't work. And that's a waste of the patient's time, a waste of our time. We'd much rather transition past that. And as we'll focus on in a little bit, focus on the no. We want patients to kind of come to the conclusion internally, psychologically, that they're saying a definitive no to more of the same, that I don't want to continue doing the same things that haven't worked. I am looking for something different. And they need to start to open their mind psychologically to a different treatment paradigm, a different treatment regimen. Our examination historically used to basically take a vision. It would be a 20/20, 20/40, whatever the vision was, but there'd be no commentary. And we deprive ourselves of all the insight our staff members, our workup technicians could give us when it's just a number. It's much more useful to me to have a 20/25 minus with lots of fluctuation and lots of sort of a soft 20/25 minus commentary from my workup technician, because I know that patient probably has some element of evaporative dry eye, tear film instability, and that's why their vision was sort of fluctuating. It was a soft 20/25. Same thing with an autorefractor. We get into the habit of relying on our autorefractor, believing what it says. To some degree, autorefractors can be random number generators. And so we want to do a manifest refraction with context. The patient was answering sort of plus or minus. One moment they'd read the line, the next moment they couldn't read that same line with the same refraction in the phoropter. That kind of commentary and contextualization is really, really important. And I lean heavily on our entire technician team and workup team to tell us that. In terms of other diagnostic testings too, when they're doing a topography, if they see a lot of zones of dropout, if it took 15 attempts to capture a good quality image on their topography, that's helpful for me to know, not just looking at the topography or the 15th or 16th successful topography in a vacuum. We do a narrow focused eye exam, right? The patient's chart would say, or the appointment book would say they're here for a dry eye evaluation. What do? We go right and look at the cornea and look at the tear film. We'd stain them and comment on the staining pattern, and then try to sit back and try to figure out a treatment plan, which oftentimes would result in more of the same. We'd have a sort of non-specific diagnosis. We'd call it dry eye. Dry eye hardly sounds like a disease state. It sounds like dry skin, dry hair, not really such a big deal, and certainly not something that requires a proactive approach. Our treatment recommendation, more of the same, more drops, more artificial tears, more over-the-counter stuff, more burden on the patient. And so patients would often give us a significant amount of resistance, not only to the treatment recommendation, but even before that, to the diagnosis itself. I don't think I have dry eye, doc. My vision's just blurry. The glasses you gave me are the wrong prescription. The cataract surgery you did for me, I think you you put the wrong lens in because I'm not seeing that great. And so all of our treatment recommendations historically used to put all of the burden on the patient to comply with that regimen, to stick to it, even when they were potentially having side effects of the regimen that we hadn't educated them on beforehand, or there's facing significant cost constriction with treatment recommendation, and they're not seeing any relief, right? Relief is 6 to 8 weeks away or 4 months away with compliance, and they have trouble sticking to the program. And so we sort of failed our patients by not even facilitating compliance and letting them know how long they'd have to do this, not painting a picture of what happens if you don't do this, what could happen if you don't do this, that this is a progressive condition, it could get worse. And then our follow-up regimen would be sort of vague and inconsistent. We'd have a distant follow-up. The patient would have no idea of what exactly are we looking for the next visit. What are we planning on doing at the next visit? What's the next step if the current treatment regimen that you've suggested doesn't work, or it works in part, but not enough? And so having a forward-looking treatment plan so that the patient has an expectation of what to expect as the next step, the next regimen, is really, really helpful. So we want to start kind of moving away from this traditional approach and taking a much more proactive approach, an interventional approach, so that every visit isn't exactly like a restart of the first visit. So our treatment approach really has to change. Traditionally, we'd rely heavily on topical therapies. Patients would be left to their own devices of how to get these drops in, how to deal with side effects. We'd oftentimes provide no instruction of how to even get a drop in. So I've seen all sorts of things. Patients putting the tip of the bottle right into the caruncle and squeezing the whole bottle out. We've seen it all. Funnels, eye drop tubes, I mean, you name it, we've seen it. Patients will be left to go shopping for drops and they'd be stuck in the pharmacy aisle like we've all been in. And what are they supposed to choose? They've had no direction from us. And so, again, the patient in this scenario carries a lot of the burden for themselves versus taking a more proactive treatment approach, things that we can do in office, interventionally, MD, OD alike. These are things that any of us have the skill set to do in justified circumstances. And when we do this, it creates an immediate impact on the patient. And the drop therapy then is a lot better complied to because the patient's already seen some benefit from the interventional therapy. And so this helps us share that burden and relieve the patient of some of that burden. And they're far more likely to remain compliant on recommended topical therapies. So this interventional approach really does allow for a lot of benefits. Faster onset of action and timeline to relief, rather than doing more and more of the same or iterations of the same. Higher patient satisfaction, higher quality of life. They spend less of their time and their lives spent doing eye drops, thinking about their eyes. They come in, they have a treatment, they go about their normal lives, and they don't have to think about their dry eye until their next visit. Less burden on the patient for compliance. This humanizes the whole process. I oftentimes am telling my patients with my own dry eye, Mrs. Smith, I forget, as much as I'm going to preach to you about using artificial tears and warm compresses and so forth, I get home with my 3 kids and I forget to do it. And that means that I need to do more of these tear care treatments, more of the lacrophil, more of the other things that are interventional in the approach. But if you're really good about doing your warm compresses, Mrs. Smith, it means that you'll need fewer of these interventional treatments. And so it helps us leverage the interventional treatments to better enforce compliance on the other parts of the regimen that we might recommend. This also helps us appeal to patients' natural desire for homeopathic, natural regimen versus pharmaceutical approaches or surgical approaches, right? There's almost every single patient this resonates with. When I tell them, for my own dry eyes, I prefer getting my body to do what it's naturally supposed to do, if I can naturally, rather than putting a chemical or a drug on my eye. When I say it in exactly those words, usually patients are saying, yeah, I agree with that approach. Let's hear what you have to say about that instead of prescribing yet another drop. We've also done some studies now. The Sahara study, which was published earlier last year, was the first study of its kind comparing interventional therapy, in this case, tear care, which is a thermal heat expression of the meibomian glands, versus a topical therapy versus Restasis in this Sahara study. And we found that on every single metric, a tear care treatment was superior or equivalent in terms of OSDI score, staining score, everything. Every single metric we looked at, tear care was better, if not better, equal, or if not better, than 6 months of compliant, documented use of Restasis. And so we did a cost analysis, an economic cost analysis of that, with 1 tear care treatment versus 6 months of Restasis. Patients and the medical system actually save money with an interventional approach, and their quality of life is better. And the actual clinical outcome, clinical effect and benefit is better, if not equal. This is also allowing us to put each of our skill sets and time to their best and highest use. My best and highest use of my skill set is to be in the OR 5 days a week, 6 days a week, if I could get there, right? Our optometrists, they're brilliant. Their best and highest use is to provide brilliant, compassionate medical care, non-surgical care of all of these primary care eye diseases. Our staff members, best and highest use is taking good care of patients, educating them, helping our staff work efficiently and have better throughput with patients, a better consumer experience, if you will. Their time is not best spent answering prior authorizations and callbacks about side effects and the cost of the drops and pharmaceutical substitutions and so on and so forth. When you actually look at a cost analysis, an economics cost analysis, every time one of us writes a prescription for a drug, we're now actually costing our practices money. We're not producing a dime of extra revenue for writing the prescription. The pharmaceutical companies makes the money. But we actually lose money because now we're enlisting a whole lot of staff time answering denials, prior auths, et cetera, patient callbacks. And that time and manpower is best used to create and formulate and curate a better patient experience for us and our patients. Topical therapies can then become an adjuvant therapy. They're complementary to the interventional therapy, and the two can be leveraged against each other. So, Mrs. Smith, if you just do your homework, you brush and floss on your own, you'll need to see the dentist less often. And so this is a very useful way to enforce compliance. Again, I mentioned this revenue for the practice versus big pharma and less time spent with your staff members doing things that are not the highest and best use. Let's talk a little bit about the dry eye diagnosis specifically. We used to talk about dry eye as, again, like it was this vague kind of complaint, not an actual disease. I'm very careful when I'm talking to patients about ocular surface disease that I refer to it as dry eye disease. We sometimes forget when speaking about it broadly to patients that there are different forms of dry eye disease. We have to remind ourselves that there's aqueous tear deficiency, evaporative, MGD-driven dry eye, mechanical dry eye, formerly known as conjunctivochalasis, and mucin deficiency, commonly caused by chronic inflammation, chemical exposure, surgical impact, etc. And we used to think of treatments as very siloed, right? So here's my best treatment for aqueous tear deficiency. Here's my best treatment for MGD. Here's a referral for mechanical dry eye to a surgical specialist. Here's a best treatment modality for mucin deficiency. But I've never in 20 years of practice ever seen a patient that has only one form of dry eye. It's best represented maybe this way, a very highly overlapped Venn diagram, if you will. And it's useful to talk to patients in the context of you have multiple forms of dry eye disease I can see, and each component of your dry eye disease or type of dry eye has its own targeted therapies. The reason that you may have noticed that the therapies that you've tried in the past haven't worked is because they've not treated the other components of your type of dry eye, or they've only targeted the wrong type of dry eye. You have evaporative dry eye disease, you have mechanical dry eye, and artificial tears and immunomodulatory therapies are really meant for aqueous tear deficiency. So, of course, it's not going to work. So this helps patients understand why past therapies haven't worked, and now the recommended therapies will. It allows us to kind of rephrase our diagnosis. Your type of dry eye disease is best treated with this type of targeted therapy. This other component of your dry eye disease is going to be best targeted with this therapy. We can't do one or the other. We have to do both. And so this allows patients to kind of better understand treatment approach. The patient education process doesn't start with just the subspecialist. It has to start well before they ever come to see me. And I could literally see dry eye patients all day long, 24 hours a day, 7 days a week, 365 days a year, and never see them all. This is not the highest and best use of our time. We really have to make the best use of our community of MDs, ODs, PAs, optometrists, both internally and externally. Our staff members have a wealth of knowledge. I pride myself on the fact that I feel like I've invested in my staff so well, educated them so well. Most days of the week, I could probably not show up to clinic and they could run my clinic just fine 99% of the time and get the diagnosis right, the treatment plan right. They know what I'm going to do before I do it. They can read my mind. And so this kind of investment is really, really important. So if we're not interfacing with our community of members in our industry, then we're really losing a lot of power here. So that education really needs to happen with every single person in a patient-facing role, from someone answering the phone to a door greeter, to our waiting room attendant, to the workup tech, to the testing technician. Everyone should be equally skilled and schooled and scripted on the dry eye messaging. This is why I'm doing this particular test. It's going to help Dr. Desai figure out what type of dry eye disease. This kind of echoing of the messaging from everyone along the pathway, from phone room to workup technician to physician, surgical counselors, schedulers, things of that sort, is really, really critically important. Disease state education, treatments available. I've seen this many, many times in practices that I consult for as I travel around the country. Patients, physician staff don't know what treatments are offered by the physician. We ask them, what does your physician offer for dry eye? And they don't know. And so you're losing a lot of advocacy from your own internal staff members. We need to have simple explanations and analogies, and everyone needs to be armed with those so that we have consistent messaging. We're using similar explanations, similar analogies, so that there's consistency. And then I like to talk about process, procedure, predictions. Process is sort of the way to the diagnosis and the treatment plan. Everyone along the way needs to kind of talk about, I'm doing this, or we're working up this, we're asking these questions, because it's going to help the process of determining a diagnosis, coming up with a very, very tailored treatment plan. That's the process. The procedure, everyone needs to know what the procedure is like. Better yet, they should have experienced the treatment themselves. And so they need to be able to talk in a personalized way to a patient, telling them what this procedure is like for them personally, what impact it's going to have. And this is where we talk about predictions. What are the things that you're going to notice after we do the treatment? It's normal to have a little bit of blurred vision or excessive tearing after we do lacrophil. It's normal to have a little stinging and burning. Those kinds of predictive statements help reduce the number of callbacks, sets expectations really, really well. And I think this is perhaps the biggest loss if your patients are working with staff, or you're working with staff that have not benefited from treatment themselves. So none of us should have staff members that have dry eye that haven't had and experienced all the therapies that you offer, because this allows each one of us. I can do this personally and say, this is the way I treat my dry eyes. But it's really powerful when Morgan or one of my workup technicians or someone that's in a testing position can say, this is how I've been treating my dry eyes, or Dr. Desai's done this for me and it really worked and it was painless and easy. Or those kinds of personalized testimonials are really, really helpful to patients. So I've modified my treatment algorithm over the years. It's not as complicated as it used to be. Let's talk very quickly about this. Morgan kind of talked about the flow, the collaborative approach. I, again, don't see typically dry eye patients de novo myself. I like those patients to be kind of triaged through PAs, optometrists, both internally, externally, because there's no reason for me to be the first person to tell a patient, use artificial tears, and these are the specific types. There's no reason that I should be the first person to tell them, use a Bruder mask, get on some nutraceuticals, let's do some lacrophil, let's do some punctal occlusion, let's think about systemic involvement, establishing a diagnosis. These are all things that can be done at ground level with our optometric community, our PAs, internally, externally, and so forth. And so we kind of get down to a pyramid structure where I'm getting the most severe patients that really need interventional therapy at this point. My treatment approach, and when I walk into a room, my approach is quite the opposite of the way we were all trained. We've all been trained to go through a medical history, get the history, do an exam, assimilate all of that in our minds, come up with a diagnosis, and then present the treatment plan and the diagnosis to the patient. In fact, I do this all backwards. I walk into the patient because we don't know what the exam is going to reveal when we walk in until we've done it. What we do know is what treatment modalities we have. I know the full menu of everything that I can offer a patient. And so when I walk into a room, I walk in saying, I'm going to offer this patient tear care, IPL, systemic evaluation, Super K with Procara, serum drops, a reservoir restoration procedure, all of these different options until proven otherwise. And when I walk into the room, then my exam becomes very treatment focused in essence. So I'm looking for evidence on the exam, very focused, detailed, that supports me offering this particular treatment. If I don't find that finding that supports using XDEMVY, I'm not finding Colorette, well, then I'm not going to offer it. But it allows me to have a much more focused exam that then becomes more proactive and therapeutic for the patient, wastes less time, and it forces me to have a much more focused exam that's not just on the ocular surface, because now I'm having to look at their skin. Do they have rosacea? I'm looking at their fingernails. Do they have psoriatic arthritis or rheumatoid arthritis? I'm looking at do they have other atopic disease, psoriasis, eczema? So I have to take the whole picture in. I'm flipping their lids. I'm pressing on the meibomian glands because I'm trying to find evidence that supports my treatment rather than trying to find a treatment that matches my exam, if that makes sense. This allows us to have a much more efficient time with the patient and move them on. Despite all of that, despite this approach, there's some paradoxes that we face. No relief from artificial tears. Well, if it's tear deficiency, if it's dry, make it wet, it should work. Why doesn't it work in every patient? If all dry eye is inflammatory based, why don't immunomodulatory therapies or steroids work for everybody? Why do patients still have dry eye disease and findings? Why is it that some dry eye patients have excessive tearing? That doesn't make any sense. That oftentimes breeds resistance to treatment recommendations because they don't believe the diagnosis. And why is it that some patients, we see them, they have florid ocular surface disease? There's no doubt about it. They have stain without pain. There's no physical symptoms. Why is that? So there's some conundrums, and this oftentimes results in a lot of resistance to acceptance to therapy. So this is my unified theory of ocular surface disease. All dry eye therapy, or pardon me, all ocular surface disease is the same disease because they share the underlying pathophysiology of inflammation and inflammatory tissue damage. It's just different manifestations of the same disease based largely on how long has it been there and how severe has it been. So patients will all start out with dry eye disease or mild keratitis. No one ever wakes up one morning with a melt, right? They had to have started somewhere further along earlier in the process with mild disease state, with mild inflammation. It's only then after a period of time untreated that they progress to get basement membrane disease, recurrent erosion syndrome, Salzmann's nodular, corneal melts. What else is at the end of that spectrum? With chronic overexpression of matrix metalloproteases, chronic inflammation, we get Tenon's degeneration, we get loosening conjunctiva, a foreshortened fornix. That's the definition of conjunctival chalasis or mechanical dry eye. Once they have a mechanical problem, all of the biologic treatments, the medical treatments, are not going to work because now they have two problems. They have a medical problem, a biomedical problem, and they have a mechanical anatomical problem for which there's only a surgical solution. At the end of that spectrum, we also have another disease state or disease entity, neurotrophic keratitis. Patients who have stage 1 neurotrophic keratitis are indistinguishable from patients who have dry eye disease. It's just that they have stain without pain. They have evidence of ocular surface disease, just no physical symptoms by definition. And so I want to spend a little bit of time talking about NK because it's a really good example of how our entire team really has to pull it together in order to best treat patients. NK, we forget that there's 3 stages. We forget it's progressive, just like dry eye disease. No one ever woke up one day at stage 3. They had to have progressed from stage 1 and then stage 2 and then stage 3. Patients with stage 1, as I said, indistinguishable from dry eye. So we have to do corneal sensitivity testing. If the patient comes in for a dry eye evaluation and they already get numbing drops at stage 1, that means that we have to bring the patient back for corneal sensitivity testing another day. That's wasted time for the patient and for our practices. So our workup technicians are flagging patients that we know are going to be at high risk for NK and that might need corneal sensitivity testing, and they don't put drops in. They let us do corneal sensitivity testing right then and there. then we continue the rest of the workup. This allows us to make a diagnosis of NK and treat it at the point of service. That early diagnosis allows for better care. And thankfully, we have better treatment options between amniotic membrane grafting and oxervate or Synedrimin, the nerve growth factor. Now, Synedrimin, great medication, but as we know with any other treatments, particularly topical therapies, are only as effective as they're going to get to the target tissue. So we talk about things like bioabsorption, bioavailability, the pharmacokinetics of a drug, the vehicle of the drug, because we need it to get and penetrate into the ocular surface, into the tissues, the target tissues. But the biggest barrier to target tissue penetration is compliance and access to care. Synedrimin, oxervate, a course of 8 weeks of therapy costs $95,000. And so in order to get access to this medication, the patients have to go through an approval process that involves their insurance company, other resources, and there needs to be a central cog in your practice to manage that transition process and that application process. If that doesn't happen, if there's not good enough documentation in the application process, your patient's going to spend weeks, if not months, getting denial after denial, and they'll never get access to this great medicine for their disease state. Now, oxervate's a phenomenal, very dramatic example at $95,000, but the same is true whether it's Restasis or Xiidra or Cequa or any other therapy we might recommend, particularly those interventional therapies that are not yet covered by insurance. And so our team members really have to be integrated into the process from stage one, from the point of diagnosis and even before diagnosis, so the patient knows to expect that there's going to be a process of approval. We need to keep track of that process and keep track of where the patient is in that approval process. Documentation is key. So they're playing a timely role in diagnosis and treatment. They're assessing symptoms or lack thereof. They're testing patients for these conditions at the right time in an efficient way, providing documentation of stage and severity. We're requiring documentation of medical necessity. This is, again, true not just of oxervate, but Restasis, Xiidra, Cequa, any of the new dry eye therapies that are out there. And so documentation, having templated documentation is really helpful in your EMR. Filling out the patient assistance program forms, things of this sort, following up the patient, following up with the insurance coordinator, following up with the industry, the manufacturing coordinator, and the doctor to make sure that we have follow-ups in a timely way when the patient is actually getting the drug. We can guide them through it, set expectations right. It's awfully helpful to have pre-populated, pre-filled, pre-signed forms so that all it is a matter of saying this is a right eye patient with stage 1 NK. This form is already signed. We've gotten denials for these medications before because I forgot to sign the form, or we forgot to have the patient sign the form, or because we forgot to document which eye, or forgot to document, even though it was done, we forgot to document that corneal sensitivity testing was performed and how. And so we can avoid a lot of these delays of treatment and inefficiencies if we have the right documentation. And I'll tell you, Morgan is my lifesaver. She is like the central cog in that wheel. It really is such a luxury to have someone like Morgan in your practice that you can identify, that has the bandwidth, the energy, the meticulousness to kind of follow up with all of these things so that we as clinicians can focus on treating the patient, making the right diagnosis, making the right recommendations, educating our patient as to why this is going to work where other things have failed, and then allowing our team members to really fill in the gaps therefore and there forward. Let's talk a little bit about communication very quickly. Oftentimes the physician is the only one and the first one to explain things in technical terms. If you've ever been talking to a patient and you look around at your staff members that are behind you and they look something like this, you got problems, right? Your style of communication is not engaging enough. If you're boring your technicians, or if they've not heard this before, or they're not able to follow the same script, your technicians, your staff members, everyone has to be engaged and be knowledgeable on the treatment enough so that they could provide the explanations themselves. They need to know what treatment offerings there are, why and when we might use them, what to expect with those treatments. We need to make sure that the treatment recommendations are very tailored and contextualized, so it's not programmatic or robotic. And then we have to be aware that sometimes when you have many staff members, that we can say the same things oftentimes, but patients can hear it differently. And so we need to make sure that we're using the same analogies, the same language, so that there's no space between what one person says and the other. We need to avoid this analysis paralysis. Oftentimes, we don't know what's going on in a patient's head, which impacts their external decision-making process. We want to avoid this sort of dramatic scene that plays out many times. You have dry eyes? No, I don't. Yes, you do. No one's ever told me that before. Well, I guess I'm right. They're wrong. Well, doc, my eyes feel fine. I'm here for my blurry vision. Okay, yeah, right. Let me tell you how to treat the dry eye. And the patient leaves, right? And so this kind of scenario plays out time and time again in practices all around the country and around the world because patients are rejecting the diagnosis. And then it's really hard to move on to focusing on treatment plan. So we have to leverage our understanding of patient psychology to better communicate with them and better position them to make good decisions for themselves. Instead of saying you have dry eye disease, which elicits an objection, we can rephrase that, leverage patient psychology and get a no answer first, right? Using some negotiating tactics and psychological leverage here. The way I phrase it is, Mrs. Smith, I can see evidence when I examine your eyes under a microscope that you've probably had dry eye disease for longer than you've even realized. That's a very different way of saying the same thing, but that avoids the objection, right? Mrs. Smith will say, well, my eyes feel fine. I guess I didn't notice I had dry eye disease. The doctor's right. And it kind of loops back and becomes a self-fulfilling statement. Patients don't know what they actually want or need. If we ask them what they want, they say, I want a drop that works better. Oftentimes, they've not heard of other interventional therapies. And so we have to kind of take the onus of responsibility on introducing these other treatment options so that they have a clear mind, a good set of expectations of how to make progress in a rather confusing world. Now, I often say that there's yes, there's no, there's maybe. Maybe is an okay answer, but we're all trying to get to yes. It's commonly said that the road to yes is paved by a lot of no's, but not all no's are equal. Obviously, in this scenario, no, it's not a very good no, but there are very good no's to elicit. And what I'm talking about is something that I've learned by what I think should be required reading across our industry. A book written by Chris Voss, the former head FBI negotiator, hostage negotiator for the FBI for many years. He's now a speaker and a trainer on negotiation and communication. And he taught me a very valuable lesson that every negotiation, particularly high stress ones, high stakes ones that he was involved with, begin with a no and should begin with a no. That's a successful negotiation. I implemented this right away in my home. High stress situation every night that plays out with my wife. What do you want for dinner? And we'd go around and around, whatever you want. I don't care. It doesn't matter. And we'd make a suggestion and my wife would shoot it down. And so we'd go on around and around. What I was looking for was a yes answer, but really I'd be best served by actually aiming for a no answer. So I learned to rephrase. If I really want Mexican food tonight, I'm asking my wife, sweetie, would you really object if we had Mexican food tonight? It's a question that's designed to elicit a no, I don't mind. I wouldn't strongly object to that. Boom, we're ordering on Uber Eats. So eliciting that no answer, eliciting the no answer from the dry eye patient who's saying, no, I don't want more of the same. Yes, I do want something different. No, I don't want to feel this way. Yes, I want to feel some progress. No, I don't want to spend more money on drops. Yes, I'd be willing to spend some more money on something that actually works. So getting to yes really relies on us establishing trust and knowledge, eliciting definitive no's, so that we're saying no to more of the same, using bad words. What I mean by that is saying things like, Mrs. Smith, if a doctor were to neglect this problem and rush you off to surgery or prescribe this drop, you may notice X, Y, and Z. You're going to get a terrible result. It's not going to work. You're going to spend a lot of money. Um, Mrs. Smith is saying, no, don't neglect it. No, I don't want to experience that. She's kind of definitively cutting away certain things, which then forces her psychologically to be amenable to something that is going to work and what our treatment recommendations are, particularly when they're customized and personalized. What I mean by customized is this is going to work for your particular scenario, your type of dry eye. Personalized means this is what I've used myself. This is what my technician has used. This is what I've put my own mother on. And it works. I look forward to it. It feels good. It's worked. We want to align our interests and kind of help enforce compliance. And we want to humanize the regimen. As I mentioned earlier, I'll commonly tell patients, look, I'm going to preach to you all day long about using artificial tears and using the drops as I instruct you to, warm compresses, etc. But I myself forget, and it just means that I have to rely more heavily on these interventional therapies. And so we can reinforce compliance and adoption to other treatment modalities a lot better by this communication style. We try to reinforce with patients that if you want something you've never had, you got to try something you've never done. And that's true in our practices as well. If you want to run a practice in a way that you've never had run before, you've got to do some things that you've never done before. And that includes integrating your staff members and really investing in your team.
The last module is It Takes a Village. Something that drew me to joining this practice and makes me so proud to be a member of it each and every day is that in the same way that Dr. Desai manages dry eye and cares for these ocular surface patients, same way that I manage my glaucoma clinic, and that we really focus on a collaborative approach between all of the members, not only under the roof of our practice, but all the other healthcare providers in our community. So we're going to briefly talk about how important each of those members are in the process of managing these somewhat complex patients. When it comes to optometrists, ODs are often the entry point into the eye care arena. Many of these patients have been in our offices throughout the United States, treating their myopia, their astigmatism, and you have had the opportunity to develop these very real, very tangible relationships with them. They lean on your expertise. You're the doctor that gave them the glasses when they were 5, 6, 7, that they could see the board, the one that got them first into contact lenses. There are so many psychologically positive connections that these patients have with you as their optometrist that when you start to make recommendations on managing other things outside of just their refractive error, they really do trust you. We have a very unique role within the healthcare system, and it's one that you actively must leverage to care for your patients. At the same time, it can be beneficial to your practice. So often we're not only the entry point, but we're also initiating the first line care. Something as simple as artificial tears, and not just any tear. Give them the name of a tear, give them the coupon, talk to your industry reps so that you say, Mrs. Jones, I want you to try this tear and this is why. Patients are happy to accept your recommendations a lot of times if they are told why. Oftentimes, ODs can prescribe appropriate medications, starting patients on cyclosporin, lifitegrast, perfluorohexyloctane. We've got all these wonderful molecules in our toolbox, and we're all in different type of practice modalities. And so based on your individual practice modality, practice to the comfort that you feel best is in the best interest of the patient, and that can include prescribing medications. I have colleagues that are basically magicians that fit these specialty contact lenses. It's one thing to try to convince a patient to use drops to keep their vision, but it's another thing when my colleagues upstairs within my own community, outside of the walls of our practice, but even upstairs within my own practice, are able to fit some of these lenses. So part of being a good kind of an overall global team player or national team player is understanding who in your community is fitting these lenses. Is it in your own practice? Is it down the street? Oftentimes we don't refer enough into one another. So if you don't have an IPL, but Dr. Jones, the optometrist down the street, has the IPL, there's so many tools that are out there. So get to know the members of your community and help them out, and make those recommendations, because that patient that has that very real relationship with you will take those recommendations as they know it's in the best interest for their management of their ocular surface disease. surgeons, they're not only just the fighter pilots of our community, but they have a lot of skill sets that even in optometrists that are in patients with max scope, they're still able to get that scalpel blade and take that patient up to the OR, or to do procedures that you may not feel comfortable with yourself, depending on each doctor's individual situation. They're the secondary and tertiary care that's not just ocular surface, but when it comes to other conditions like refractive cataract surgery, pterygium removal, so many things are necessary for surgical intervention. And you, as the optometrist, have the ability to set them up for success with that surgery. So you're making the surgical referral, but that patient will remember that you're the one that sent them to that surgeon. So if you can maximize the ocular surface, you're not only helping the surgeon that you're sending the patient to, but you're helping your patient in the long run, because they're going to have the maximum outcome that they could possibly have. And then they will also tell their other friends, hey, Dr. Jones, my eye doctor that's done my glasses, started me on this treatment, got me set up, and now I'm seeing better or feeling better than I ever have. So you get to become a very integral part of that patient's story from a psychological perspective, which is incredibly important for practice growth and practice building. Understand which surgeons are doing which procedures. And I'm not just talking just cataracts or just pterygium removal. In the glaucoma space, I know every MIG that every surgeon, and not only within my own practice is doing, but within my community is doing. So as an optometrist, if you have the opportunity to refer a patient that has glaucoma into a cataract surgeon that's also doing a concurrent MIG, it's a win for the patient. Oftentimes there's a window at which these are only available to be covered at the time of cataract surgery. And not only do you get to help the patient manage their glaucoma, you give them a good refractive outcome, but you're also the hero now, because when that patient comes back to you, you get to take them off of that prostaglandin, you get to take them off of that 2 to 3 times daily aqueous suppressant that's chewing up their cornea. And then you also get to be an additional part of that story even after that surgery. So it's super, super important that you're managing these patients, getting them to the surgeon when necessary for all conditions, not just the management of their ocular surface, but also if they do have refractive conditions that you send the patient, know what the expectations are with the surgeon, whether they want written communication, text communication. We are a collaborative team. I always talk about how there's this, this avalanche of glaucoma patients that are out there, and it's all hands on deck. Well, if there's an avalanche of glaucoma patients, there is a tsunami of dry eye patients that are out there. Industry is one of your most underutilized resources out there. I cannot tell you how many doctors tell me, "Well, I don't let pharma reps in my office. What's working is working." Well, what's working is clearly not working if we have millions of our fellow citizens out there walking around in our communities with untreated or undertreated dry eye. You don't want to be one of those 2.3 patients that a patient saw before they got to a next level of care and are actively addressing their disease. So utilize your local reps. They're not only there to give you samples and coupons, they can keep you up to date. They've got medical science liaisons that can keep you up to date on what's in the clinical pipeline. So you'll know ahead of time. I'll give you an example. When a medication called perfluorohexyloctane was getting ready to hit the market, I had patients already identified in my mind that would be excellent candidates for it. And I said, look, Mrs. Jones, there's not something that's out yet, but at your next appointment, we should have something that's out there. And you set the expectation for them. You put yourself into a different category by letting them know. You become almost like a fortune teller, but you listen to them, just like what Dr. Desai says of what hasn't worked. So then when there are things on the horizon that might work for them, even if they try it and fail it, you've at least given them hope and an opportunity for something that they are able to do. And oftentimes industry can give you insight on why PAs are or aren't working, and they are the critical role in getting patients access to medications like Oxervate that have the potential to regrow corneal nerves. The very last slide here as we come home. This is the glue that holds I got too excited for me. I got too excited. One moment. That was an operator error there. Let's go back, because honestly, this is the most important slide of this entire slide deck. When I was a military officer, I was taught, take care of your people and they will take care of you. And that is so incredibly true. All of our staff members, regardless of what modality we practice in, whether you're in a refractive, you're in a tertiary care, you're in an academic center, all of the staff members that help, from the first person that opens the door to the coder that's in the background doing my billing and coding, they are so important to what defines the quality or the nature of the practice, that feel. When you go to Disneyland or Disney World, you get a feel that's there that's very different than if you go somewhere else. And it's because of the culture. So by investing in your staff, you're investing in your practice and investing in yourself. And patients may tell these staff members barriers to compliance that they may be too embarrassed to tell you. And your staff members can help you be on the alert for those. They are such an important role because if they don't know what services that you're providing, whether you have an IPL, whether you're doing tier care, and they can't answer those questions. So invest in your staff and keep them updated on, even if you're getting something new. We're getting a new laser here in the next few weeks. And almost everybody in our staff, even if they're not in the glaucoma space or the dry eye space, they know it's coming. So we really do work hard to try to make sure that our staff members know that they're a part of our family. I love this image here of this sailboat because I could not run a glaucoma clinic to the extent that I do without the wind that is moving this. I might just be the rudder of the boat, but my staff are the ones that are busting their tails, working hard, collecting the information for me so that I can make the decisions to help guide that patient in the best direction. Once the staff understands not only the benefits of the therapy, but the goal of the plan, if you're verbalizing it to the patient in the room, guess who knows the plan? The people in the room. But if your staff on as a whole, if you start having these like quarterly luncheons hosted by industry, they have the ability to really know what your long-term goals are. And what that does is it makes you and your practice an invaluable part of your community. That picture of those bricks there is so important because bricks were made for the mortar to erode over time and they can be repaired. Think of the bricks as the surgeons or the doctors in your practice. And you have some staff members that may be with you for a lifetime. Some may be there for just a short period of time. But whatever the time period they're with you, if you invest in them, they become a critical role in keeping your practice working cohesively, but also making sure that those patients get the best quality of care that they can. And we really appreciate, we value your time. We're so happy that we took the time out of your night. I would like to bring the entire presentation home by asking Dr. Desai the key question. What is the one clinical pearl that you have to running such a successful dry eye center, one that my glaucoma patients utilize on a daily and weekly basis and has really changed their lives and impacted their quality of life?
I think it's a great question. And I think you actually already answered it, Nora. I think investing in educating your staff, getting them engaged, it's going to make the patient's life easier. It's going to make our lives easier. It allows us to be just so much more cohesive and efficient. It allows us to operate at the highest level of our skill set and really make things much more efficient in terms of timeline to relief for patients. I think every hour, minute that we invest in training our technicians, our teams around us on what we're offering our patients, how we explain things to patients so that they can kind of continue that and stay on message is the best investment you'll ever make in your practice. So again, I will echo Nora's thanks and gratitude to all of you for joining us tonight. I know we didn't leave quite enough time for questions, but if any of you would have questions for us, feel free to reach out to us online. My email address is desaivision2020@gmail.com, and we'd be happy to answer your questions offline as well. Look forward to talking to you soon, guys, and thanks again for joining us on Eyes on Eye Care.